Good morning. I'll kind of give you a background of HCA to begin with. Stands for Hospital Corporation of America. We're based in Nashville, Tennessee. Our primary business is private health care. We were founded in 1968, 180,000 employees, 4,500 IT staff, 200 plus hospitals. Our 2008 revenues were $28 billion. Our 2008 profit was $673 million. We have 15 operating divisions throughout the United States and Europe. This is the international division. We're based in London. We have 3,000 consultants who admit patients to our facilities. We have 3,000 employees working at 45 separate locations. I have 60 IT staff. We do 200,000 annual patient visits, 850 beds. They're spread between the Wellington, Princess Grace, Lister, London Bridge, Harley Street, and Portland Hospital. I've also got 5 outpatient surgery centers. I have 4 joint ventures with the NHS. I have a 15-bed oncology unit at UCLH. I have a linear accelerator at Barts in London. I have a 24-bed unit at Queens in Romford. And I have a 35-bed oncology unit at Christie's in Manchester. We recently bought London Oncology Clinic, and we're going to franchise that. We also have multiple imaging and consultant suites scattered throughout London and the surrounding community. All right, now for those of you in the public sector, you may not believe this, but there's only 3 reasons why we invest CapEx into IT. I don't need to cost justify it. I don't need an ROI. I don't have a steering committee. All right, number 1 reason is to align consultants with our facilities. So we asked the physicians, what would it take for you not to be a splitter? So if you would send all your patients to Princess Grace and not half to Princess Grace and half to London Clinic, what would it take? And they said, well, if you could give us a physician portal. So what we offer is a computer system that's so easy to use, it would be a substantial disincentive for the consultant to send his patients to a non-HCA facility. So it's web-enabled, anywhere in the world, anywhere on their BlackBerry or their iPhone or their iPad. I do have my iPad with me. If you'd like to see it at lunch, it's a killer app. I'll demonstrate it to you. All right, the second thing is to improve patient safety. And this is primarily why we got the Tracline Panasonic. In order to blood tracking, vital signs, medication administration, and bedside medication verification. These are all application systems that require input at the patient bedside. And if I have time at the end, I can come back and explain each of these systems in more detail, but in 20 minutes, I don't think I can do it right now. But this ticked all the boxes for what we needed. And the third reason is to streamline the patient journey. So, we have patients, they don't like to stand in queues. So when you leave the consultant's office, they give them a little brochure that says, hey, when you go home, either on your BlackBerry or on your iPad or whatever you have at home, you can put in all the registration questions that they're going to ask you when you come to the hospital. So when you come in, you don't even have to stop at the registration desk. We have some kiosks, so it's just like British Airways. It's a touch screen, you key in your name, you read the patient consent form, you electronically sign it, and you're off to have your procedure done, all right? Now, that's going very good. We've got it at London Bridge, and we're just moving it to Lister Hospital right now. I've got 2 kiosks at London Bridge. We're doing a pilot. So far, that's working very well. And I'm also going to start doing iris scans because we have a lot of people this is truly an international city, and people with the same names or same birth dates, it's hard to tell them apart. We have had some near misses. So the iris scan is the same one that's used at Heathrow, and it takes 1 second to do each eye. And not mainly for the inpatients, but eventually we will get the inpatients, but more for outpatients. If they go to radiology, if they go to laboratory, we can scan them and they say, hey, you're Mike Gogola, you're here for an MRI today. So we make sure we have the right patient. Eventually we'll do everybody. So if you come in and we say, have you been to one of our facilities? You say, I think I was. Well, we can just scan your eye, and if you were, it brings up all your patient demographics. So you don't have to keep getting asked the same thing. All right, our initial objectives for bedside data capture. Would you let me know when I have 5 minutes left? Implement a technology-based solution that would improve patient safety. So we're doing that with blood tracking, vital signs, medication administration, and bedside medication verification. We're streamlining the nursing documentation. So right now, each nursing unit has 2 desk-based workstations. And there's typically 7 or 8 nurses per floor, so they have to contend with how to get in there and get their data in. So by providing each one that's going to have direct patient care, a Panasonic device, you know, they can do that at the bedside or at another workstation, work area. So it's adding 6 or 7 devices per nursing unit. The ease of consultants' access, we've got this physician portal for the consultants. So on the Panasonic, I've only got 4 applications loaded. Meditech, which is our hospital information system that the nurses would use. Patient Keeper, which is our physician portal. Grapevine, which is our intranet that has a lot of information that nurses can refer to. And Outlook, so they can look at their emails. I've got it locked down. I'm sure some creative person will figure out how to open it up, but it hasn't happened yet. So this whole thing was a precursor to blood tracking, vital signs, physician capture, physician portal, electronic medication administration, bedside medication verification. So all of these things, you know, are a major culture change for the nursing staff. You know, they're kind of used to paper-based systems, and, you know, unless you have a sponsor or a champion, they're going to say, hey, we've always done it that way. Why do we need to change? You've never heard that before, right? No. How many people are IT people in the room? And how many are caregivers, consultants? Okay. All right, thanks. So we did some trials by nurses at Princess Grace and the Wellington Hospital in 2008. You know, I've learned that, you know, if I pick out the device and I give it to them, nobody's ever going to touch it, you know, because Mike Gogola picked it out. So I just let them pick it out. And the solution was to equip all the active nurses with a PC tablet. So, you know, there'd be some variations with the carts. I think we have 4 or 5 flavored carts. Keyboard, battery, I don't think any of them selected a battery, but as long as they use them, I don't care what they get to go along with them. Now, our hospitals are a little bit different. If you've ever been to Harley Street Clinic, there's narrow hallways, there's a lot of 1 and 2 steps, so a computer on wheels, isn't going to work as well there as it will at Wellington Hospital. So that's why I let the nurses decide what they want. The 2 finalists we had were the C5 motion tablets and the Panasonic PC tablets. We did some formal demonstrations, and the Tracline Panasonic was selected for the battery life and the weight. So this is what it looks like. There's 5 or 6 out there on the table. We selected it because it was ruggedized, portable, adaptable, it had a long battery life, it was easy to disinfect, and it had an ergonomically placed barcode reader. So if you look at this device, if you haven't really looked at it, there's a little button that the nurse can press here, and this is where the barcode reader is. So the barcode reader can read the patient's barcoded wristband. Also, we thought it was unlikely to be stolen because actually we have some verbiage that's located right here. And it says, warning, this tablet is protected and will only work at this hospital. You know, and so far, everybody's believed us. It's future-proofed. We figure it'll last 3 to 5 years before something latest and greatest comes out. And it's Windows-based. You know, I'm going to roll out 100 iPads to my consultants. You know, it's Safari-based, and it can't run everything on it. And I have to do some device management on it as well, but, you know, it's got the killer app for the physician portal on the iPad. But I don't really see the iPad working in a nursing environment. All right, we had some problems, and we also had some successes. We had some initial connectivity issues. Okay, I'm doing good. And we worked with Tracline, we worked with Meditech, and with my IT staff, we were able to resolve those, I'd say, in about 10 days. And it wasn't something that just lingered on because then it makes my radar screen. So it was a little blip, and it was gone. I've deployed 10 at Prospect House. That's where my team is based and all the computers are. So we have 10 that we use for development and for clinical nursing training. We have 24 at Harley Street, 28 at Princess Grace, 15 at Lister. And Lister, we also just did the paperless medical record, so we're using it for that as well. So over the next 2 years, I'll be rolling out paperless medical record to all our other sites. We have 41 at Portland Hospital. I ran out of money for this year, so next year I'm buying 69 for Wellington, 40 for London Bridge. I did have a rogue telemetry system. Is this covered by that Charles House rules or whatever? You know what I'm talking about? It's not? Chapman House, yeah. Is it? Anyways, I'm not going to tell you where the hospital was, but you know, we put up the access points and we started putting network traffic in for the tablets. And the telemetry system, they used to have problems with it in the past. Every once in a while, if you used the microwave, it would flip the telemetry system over to a different patient's bed. And it's a non-EEE compliant telemetry system. It's the only one we have. So it runs on 2.4 megahertz. We talked to the vendor of the telemetry system. You can break it into channels. So the vendor said they'd run on 0 and 11, and we could run on 4 through 9. I said, okay, if you can put that in writing, and if we can guarantee that, because I turned the thing off because we had it running, and all of a sudden somebody jumped over 2 beds, and I pulled the plug on it. I said, I'm not going to kill anybody with an IT system. Well, the vendor couldn't commit to this, so I had to upgrade all my access points to 5.1 gigahertz. And it took a while. We had to do some more balancing, but we're up and running now. So it's just something that you don't anticipate. And this is actually the sign that I have, and it works. Anybody have any questions? Yes. All right. My annual spend, my operating expenditures are about 6 million pounds. My CapEx is about 3 million. It's about 1.5%. Yeah.
I was interested in one of your earlier slides where you said you had 4,500 people working in IT in MCA.
Yeah, and
With about 180,000 employees altogether.
yeah.
That means that one person out of every 40 works in IT.
If you did the math, that's what it is.
Yeah, in the NHS you're lucky if you're 1 in 100.
Yeah, see, we got 3,000 of them based in Nashville. And the other 1,500 are spread out at the divisions. So I've got 60 at this division that include into that 4,500. Other questions? Yeah. Pardon me? Oh, they just play games all day. I don't know. No, I have a program director, and really we're introducing new technology to the organization through IT systems. So he's got 6 program managers that make sure these projects get implemented properly. I have applications team that has quite a few people in it to support Meditech, both clinical, financial, and administrative systems. I have a data center manager who's responsible for the data center, my backup data recovery center, the help desk, network operations team, PC help support people. And then I've got a imaging and informatics department. So these people are primarily PACS administrators, but they deal directly with the consultants. So they train them how to use all the PACS systems, plus they train them on how to use Patient Keeper, which is a physician portal. And that's about 60 people. Yes.
Do you have any change management issues?
Any what?
Change management issues. I'm just wondering, if you're in the private sector, even a private hospital, isn't it a given that people will use technology? Or do you actually have change management issues when you're implementing new systems?
Yeah, we control everything pretty much. You know, just to get your passwords or to get a system implemented, it has to be tested, it has to be signed off. Once I have the necessary sign-offs, then we move it to live. Is that what you're talking about? No?
In terms of from a people's perspective, so if you're implementing a new system, would your consultants or like go up in arms?
Will the consultants what?
Go up in arms if you're implementing a new system, or will they say, yeah, you know, we're in the private sector, you know, we've got to do this?
We've tried to get physician champions. We had 20 physician champions for Patient Keeper, you know, so that helped a lot. I just went to a new PACS upgrade, and the last time we did that, there was a bunch of whinging, so I had all the radiology managers and chief radiologists sign off that it was okay to go live. And it was very quiet afterwards. Anybody else? Yes. No. No. We know it's a system that needs to be implemented to improve patient care or align physicians with our facilities. That's all that's required. Well, you write up a business case, but it's not a make or break. It's just what we're going to do, you know. It's a narrative. Yes. Because we did a comparison between the 14 divisions in the United States and here. I've actually got half the staff of a similar sized division in the U.S. Did you have a question? No. All right, thank you very much.